Hi, good morning, everybody. My name is Trevor Hardigan. I'm a PGY-2 in the Department of Neurosurgery here at Mount Sinai, and I'm going to be presenting on some research that I've been doing in association with Dr. Kellner, looking at the association of posterior fossa AVMs with prenidal aneurysms and associated functional outcomes. We have no disclosures that are related to this current work among any of the authors. So posterior fossa AVMs, typically when we're looking at them, a rupture of a posterior fossa AVM has been associated with a higher risk for significant morbidity and mortality than those found in the supratentorial compartment. Research has shown that 84% of these posterior fossa AVMs will actually have a hemorrhage on presentation. 14 patients in a study demonstrated that they had an annual rupture rate ranging from 7.5 to almost 12% in the first 5 years, which was greater in this particular study than that found in the supratentorial AVMs. About 9% of intracranial AVMs are associated with either intranidal or flow-related prenidal aneurysms. This is thought to be due to hyperdynamics in the feeding artery, which can also predispose to increased shear stress and then breakdown of the medial wall and subsequent development of aneurysms. The flow-related prenatal aneurysms also have been shown to occur more commonly with these posterior fossa AVMs compared to the supratentorial AVMs. Nissen and Lawton recently have proposed a new grading system for cerebellar AVMs that focused on certain factors that they felt predisposed to worse functional outcomes. These namely were the need for emergency surgery, venous drainage, specifically deep venous drainage, preoperative neurological status. Understandably, if someone is worse at baseline, then they would likely not have as much reserve to handle such an insult, as well as advanced age. The association between prenidal aneurysms and posterior fossa AVMs and the functional outcomes, however, still remain an under-examined area in the treatment of this overall patient population. Previous studies either looked at just all posterior fossa AVMs, whether or not they had a prenidal aneurysm, or they had studies focused on looking at characterization where a actual resection or obliteration of the AVM was not necessarily included, and thus the outcomes on functional status were less robust. For our study, we looked at an ambidextrous review of all posterior fossa AVMs identified during endovascular procedures in our institution from July of 2016 until June of this year. The patients included in the study were determined based off of neuroradiology reports and op notes that mentioned the presence of not just a posterior fossa AVM, but also a prenatal aneurysm. The functional outcomes for the cohort of patients were looked at as an MRS at time of discharge and 30 days after discharge. Favorable outcomes were defined as MRS 0 to 2. We looked at a multitude of characteristics associated with these patients. So our patient average age was 52. We had 21 patients enrolled in the study. We had a male to female ratio of 8 to 13, demonstrating some female predominance, which agrees with some of the other literature looking at these posterior fossa AVMs. 71% of the patients actually presented with a hemorrhage. 63 of them had an EVD placed, and 42% went for emergency surgery. The hemorrhage type of the patients was also something that we looked at. Typically, the ruptures associated with the prenatal aneurysms lead to specifically subarachnoid and intraventricular hemorrhage. And so trying to tease apart the contribution of AVM bleeds versus prenatal aneurysm ruptures was something that we also looked at. So you can see that one patient had only subarachnoid hemorrhage, 3 patients had IVH only. And then we had a mixed picture of subarachnoid hemorrhage and intraventricular hemorrhage in 2 patients, intraventricular hemorrhage with intraparenchymal bleed in 4. Subarachnoid hemorrhage as well as intraparenchymal hemorrhage was not a characteristic that we observed in any of our patients. And then the most common presentation that we saw was bleeding in the subarachnoid space as well as intraventricular hemorrhage. and intraparenchymal hemorrhage. This is a particular case example that was very to many of the patients that we had. There was a 61-year-old patient that presented with a cerebellar hemorrhage, as you can see here, secondary to a found pica aneurysm. The AVM you'll see here, he had bilateral EVDs placed to deal with the associated ventricular hemorrhage, and then went for an emergency sock and decompression, after which went for an angiogram, which demonstrated the cerebellar AVM as well as an associated pica aneurysm on APN lateral angio here. Patient ended up having the aneurysm treated first with onyx embolization, and then several months later came back with Dr. Betterson for resection of the AVM for a repeat sock, showing total occlusion of the prenatal aneurysm and then also complete resection of the AVM. Our AVM was mainly located in the cerebellar hemisphere. The average size of the AVM in the longest axis was 21 millimeters. Typically, these patients were all Spetzler-Martin grade 1. 15 out of our 21 patients met that criteria, with 3 being grade 2 and 3 being grade 3. Almost all of them were associated with superficial venous drainage. And in our patient population, contrary to some other studies, we had a much more aggressive total resection or obliteration result of the AVMs, and we demonstrated that in 76% of our patients. For the prenatal aneurysms, we identified 26 separate prenatal aneurysms, the most common being pica with 16, followed by the superior cerebellar artery prenatal aneurysms, the average size 5.7. And the majority of these were treated endovascularly, 15 with 87 having a Raymond-Roy score 1 with total occlusion and 13 having a score of 2. This is showing our MRS data. So you can see here the pre-MRS data showing the majority of patients had almost no deficits, with one patient having an MRS score of 4. After the event and then at discharge, you can see a dramatic reduction in the quality of the functional status of the patients. We had a multitude of patients that were either MRS anywhere from 3, 4, 5, or 6 compared to their pre-insult baseline. One of the interesting things that we saw was that 30 days after discharge, we actually did notice a very impressive trend towards improvement in functional status, where our favorable outcomes increased in our groups of MRS 0, MRS 1, and MRS 2 compared to their discharge MRN. So the current study is looking at namely prenatal aneurysms and posterior fossa AVMs, and this is actually one of the highest single study case numbers of prenatal pica aneurysms, in particular with posterior fossa AVMs found in the literature. The pica aneurysms account for 53% of posterior fossa ruptures in the ISAT trial. Now that wasn't necessarily associated with AVMs, but it does show a propensity for these particular aneurysms to, at baseline, have a risk of hemorrhage. The functional status in our patients, as I said, significantly worsened by discharge, although there was some demonstrable improvement. The favorable outcome at discharge, as I said, was 33% in patients versus an improvement to 54% at 30 days. One of the things that I think we demonstrated in our patients was that they typically were being treated endovascularly, such that the prenatal aneurysm was embolized prior to the AVM resection. This has been discussed in terms of a treatment paradigm, whether it's more important to treat the AVM and thus try and reduce feeding artery flow as the nidus of the aneurysm predisposing to that is removed. However, the normal perfusion pressure breakthrough theory is something that suggests that the feeding arteries and arteries to the normal brain tissue due to the AVM lose their capacity to autoregulate, such that if you remove the AVM first, then you're going to end up having an increased risk of rupture through these prenatal aneurysms that you did not treat first. And so in the majority of cases, we actually did treat our patients with endovascular embolization prior to AVM resection at a later time point. In conclusion, these posterior fossa AVMs and prenatal aneurysm associations have a high propensity to rupture and then lead to a significant morbidity and mortality. One of the things that we'd like to do is extend out our our window for follow-ups to determine functional outcomes at much later time points to see if that improvement that we noticed at 30 days does continue. Some of the limitations of the study are that it is a retrospective analysis. There's sampling bias because we're a single center study. There's also some attrition bias. Our 30-day discharge sample, we have one patient that was lost to follow-up and one patient that's still awaiting their 30-day post-discharge follow-up. Also variations in the treatment paradigms and timing, namely the timing of the resection of the AVM may have an impact on functional outcomes. Some patients were treated emergently, some patients were treated semi-urgently, and then the other ones were treated months down the road. Certain references, and I'd be happy to take any questions.
Thanks a lot, Trevor. We have time for one question. If there's anybody. How do you feel SRS plays a role here? I know that some of these patients got SRS, and what plays into it?
It will play into, as I said, I think it was one of the limitations of our study thus far that we have to examine the treatments that the patients received. The number of patients in this study, while higher than in a lot of other studies examining this topic, is still small. And so for patients that received SRS, which I believe was only a couple in this study, to determine how they did as a result of the treatment of the aneurysm, the prenatal aneurysm that had as we've demonstrated, had a higher propensity to rupture versus the AVM itself, it's something that we'll have to continue to look at. The overall theory for a lot of these is that the pica aneurysms in particular, which we had the most of in our study compared to SEA or Icahn, it is felt that they are the predominant reason that these patients have hemorrhages. The AVM itself is felt to be less likely the culprit for rupture, and so SRS of the AVM perhaps might help with some of the propensity for the pica aneurysms to rupture, but still needs to be determined further.
Thanks a lot, Trevor.